my next question has to do really with clinical presentation and severity of type 2 diabetes, which you touched upon, Dr. Duru, but also the complications, and specifically for the specialists. Specialists tend to see the patients who kind of have the worst cases. And so how do you think all of the disparities that we've discussed influence the clinical presentation and then the severity of type 2 diabetes you see in your respective fields?
So I can talk about kidney disease. So what we see is that certain racial groups, usually African Americans, Hispanics, they're more likely to develop kidney disease. And by that, I mean they get it earlier at a younger age and they progress faster to kidney failure. Because for multiple reasons, some have been shown to be genetic. There's this gene that African Americans have, it's called APOL1, that predicts, perhaps explains a little bit of the difference between race. But we also see that social determinants of health, this lack of insurance, this lack of access to care, this lack of being able to afford the medications, et cetera, may also contribute because we see it also when you look at the white population, the individuals that have the lower socioeconomic status, they also progress faster than those individuals that are not in that bracket. So we see that. So not only getting the complication, but getting it earlier at a younger age, and then progressing much faster into kidney failure. And unfortunately, we also see that these guideline-directed therapies that we've discussed, like SGLT2s and GLP-1s and the nonsteroidal MRA that are now sort of the organ protective medications, at least for kidney disease. And I know cardiovascular disease, but I'll let that for Dr. Kohli. Those are prescribed in less manner, or prescribed less for individuals in lower socioeconomic status. They're less prescribed for individuals with chronic kidney disease, for women, in patients in rural areas, et cetera. So perhaps it's because the providers in those areas feel like perhaps they are not able to afford it, so why prescribe it? Or maybe their insurance in that area is different than in other areas. I don't know what the difference is, but we do see that there are different prevalence of the prescriptions by different subgroups.
And how about in cardiology?
My perspective is very similar. I would say that patients in cardiology, especially African American, Latino, they have a bigger target sign on them for many reasons. One, as you said, is potentially race biological differences, but really the reason I think is social determinants of health. So what I tend to see is a more aggressive disease phenotype. So not only is it manifesting early and progressing faster, it's more aggressive biologically. And part of that is, some of their actions, they're not able to exercise, they're not eating the right types of foods, they might be smoking, they might be drinking more soda, they might be more stressed out, they might be sleeping less. So a lot of those factors, as we talk about, it's not just your genetics, but your epigenetics. The genetics is the hardware, but how you live your life and the stresses in your life are the software for how those genes get turned on. So I do think that it's even more than we had appreciated in the past, that it's really related to lifestyle, social determinants of health, and other such choices. So because they have a more aggressive phenotype, we want to be more aggressive with them, right? We want to manage them with the top medicines, and we can't just use metformin in a patient with advanced ASCVD. We really need to use a combination therapy approach with these new fancy medicines. But wait a minute, they can't pay for those fancy medicines. They can't afford those fancy medicines because they have to make a choice between paying the rent and feeding their children versus getting the fancy medicine. So it's really hard because you're literally stuck between a rock and a hard place. You're seeing a more advanced, more aggressive phenotype of the disease. And then you're seeing a situation where you can't use the stuff that really is going to change the disease trajectory. So you're left with the generic options that you have, a little bit of, health literacy and education. A lot of them don't understand the impact of having heart disease, because until you have a big heart attack or stroke, it remains relatively asymptomatic, just like hypertension at an early age. So I think really trying to teach people not just about, the medicines, but also about lifestyle choices that can help influence the trajectory of their disease, because their disease is more aggressive, more advanced, and has more complications.
I know, Dr. Dewey, you touched upon this a little bit on your previous comment, but do you have anything additional to add in terms of the influence of disparities on clinical presentation or severity of type 2 diabetes and its complications?
Well, I will say that folks maybe who are from less advantaged areas, more disadvantaged areas, tend to wait a little bit later and show up when they have symptoms, when they have blurry vision and weight loss and just feeling very poorly, versus other people who are coming in for screening, we might catch it a little bit earlier. Usually, though, I think we're able to catch it fairly soon, often where I work and manage it. But I think the problem is, and I think I wanted to touch on this because my colleagues were talking about the new medicines that we know can save kidneys and save hearts. Sometimes care is really fragmented, and patients who aren't able to advocate for themselves because of health literacy issues or something like this kind of depend on the doctors, but sometimes the doctors will say, well, somebody else can do that. They're seeing a nephrologist, they can do that. And they'll say, well, endocrinologist can do that, or the cardiologist can do that. And we don't have anyone who's really taking the initiative sometimes to do that. And I think some patients kind of get bounced around. And we do have to do better as clinicians of coordinating and sending each other messages and saying, hey, let's think about this. Should we put the patient on this? What do you think? Let's talk to them and this kind of thing. I do think, particularly for people we know are at higher risk, like we heard, I do think we could do a little better job, and maybe with some support staff as well, but trying to make sure we have a team care approach when we know people are at greatest risk.
I think you're making such a good point because it's about kicking the can. And a lot of times people don't want to do the prior authorization. We're too busy. And so we say, oh, like you said, the nephrologist will do it, the internist will do it, somebody else will take care of it. And I think what that does, which is already a problem in this community as well, is it compromises trust as well. Because then you've got somebody saying, okay, go talk to your nephrologist about this instead of taking ownership of it themselves. And already we know in the background, many of these populations have a mistrust of the medical system, particularly as a specialist, because they're just meeting me for a brief, few encounters. It's not a longitudinal relationship over time that leads to establishment of trust. So much of what I'm saying depends on really how I conduct myself, whether I end up being a patient advocate, whether I end up saying, okay, I'm going to take care of this, even though it's diabetes. I'm going to go ahead and start this medication for you because I think it's good for your diabetes, rather than just kicking the can down the road.